Hi, my name is Alex Chang. I'm a second year medical student at OU and my research project was the effect of femoral offset in total hip arthroplasty. So why do we care about femoral offset? For a little bit of background information, total hip arthroplasty is a common orthopedic procedure with an estimated 450,000 performed each year in the United States, according to the Agency for Healthcare Research and Quality. This operation is performed for patients who have osteoarthritis of the hip, which is a disease associated with aging. We specifically looked at the femoral offset, which is seen in the image to the right. The femoral offset is the distance from the center of rotation of the femoral head, so this point here, to a line bisecting the long axis of the femur here. So again, specifically, we are looking at the femoral offset, which is this measurement right here. Lesurf et al. Determined that a normal or standard offset was between 41 millimeters and 44 millimeters. Modularity of today's implants allows surgeons to fine-tune and adjust parameters such as femoral offset and leg length. A high offset stem would move the femur further out laterally, while a neutral or low offset stem would move the femur medially. Increased femoral offset may allow for increased range of motion, decreased impingement occurrence, and increased strength of the abductor muscles of the hip. However, with this increased modularity comes the potential for adverse effects such as trunionosis. Trunionosis is essentially the corrosion of the head-neck taper junction of the femoral component, which you will see on the next slide. Current research suggests that higher offset implants have higher incidence of trunionosis and adverse events. So in this study, we performed a retrospective chart review of a single surgeon's total hip arthroplasty population from 2016 to 2022. We looked specifically at patients who received the next step in situ hip system, yielding a total of 628 cases. So you can see here this implant on the right. This is the next step orthopedics in situ hip system. The head-neck taper junction, which I referenced from the last slide, is this part right here, which connects the femoral head component to the actual femur component that goes down the patient's femur. In the study, we measured both the preoperative and postoperative femoral offset measurements, and we compared the effects of high and standard offsets, and also evaluated the reproducibility of the patient's preoperative offset in the postoperative implant. As I had mentioned, having different femoral offsets can lead to leg length discrepancies, and obviously we don't want to introduce any sort of complications with increased or decreased leg length, which may cause mechanical imbalances and different iatrogenic complications. Moving on to our results, we showed that the incidence of adverse postoperative effects, as determined by the need for revision, was higher in patients who received a non-normal offset with a p-value of 0.026. So as you can see here, we had 498 patients who had a normal offset who did not require a revision. Looking over here to the right, we had 12 patients who had a quote-unquote normal offset who ended up requiring a revision. Looking at the non-normal offsets or potential high offsets, we had 95 cases which did not require a revision and 7 cases which did require a revision. Again, this change was statistically significant with a p-value of 0.026, and this is consistent with the currently published literature. Looking at the change in offset between preoperative and postoperative offsets, we found the mean change to be negative 0.679 millimeters with a standard deviation of 8.742 millimeters. Looking at the histogram here on the right, we can see that the vast majority of patients had a change in their offset between negative 6.66 millimeters and 7.34 millimeters. Essentially what this means is that the vast majority of patients had either had a change in offset between a decrease in their offset of 6.66 millimeters to an increase in their offset of 7.34 millimeters. This is important because it shows just how accurate the surgeon was at reproducing the patient's native offset, therefore decreasing potential for iatrogenic complications such as leg length discrepancies and different mechanical complications that may result due to a drastic change in leg length. In conclusion, our findings are consistent with the currently published data that normal femoral offsets have higher rates of positive outcomes, while those with high offsets tend to have higher rates of negative outcomes. As such, we concluded that a normal offset, when possible, should be utilized and should be the goal when performing a total hip arthroplasty. This, however, is dependent upon patient preoperative parameters and measurements, as we do not want to create complications such as leg length discrepancies by drastically changing a patient's offset simply to achieve a normal offset. We also determined that preoperative offset measurements could be replicated using standardized offset implants with a 36 millimeter femoral head component. Here are my references for this study, and I look forward to presenting at the conference.